a really exciting panel for you, distinguished experts in a variety of fields, which is really exciting. So bringing together people from different backgrounds to help think about a common topic and a common theme that has vital implications for patients and communications. So first we have Dr. Josh Ewen. Dr. Ewen and I went to med school together, so it's particularly fun for me to be able to introduce him. And he is on the faculty of the Kennedy Krieger Institute. He's a pediatric neurologist whose work involves studying developmental disabilities and neurology. Dr. Hough is an associate scientist in the Bloomberg School of Public Health, and he teaches in the area of health economics and strategic planning. Dr. Macis is also Hopkins faculty, but at the Carey Business School, and some of his work is related to behavioral economics, I believe. And then finally, we have Dr. Debra. Debra Roeder's work has involved studying patient-clinician communication. So as you can see, we've got a variety of different perspectives to help think about this exciting topic. So I'll let them take over, and without further ado, welcome and thank you.
Thank you, Michelle. Thank you guys so much for having us. We know that this isn't the usual routine, and so we very much appreciate your having us here today. I'm the, I guess, the clinician of the group. We'll very quickly pass the microphone to my distinguished colleagues who do research in areas that touch on informed consent. And I guess the genesis of this was when I was on the Kennedy Krieger Bioethics Committee. I remember a consult that involved the placement of a gastrostomy tube, and some of the differences in understanding between the medical team and the patients came from, I think, how the procedure was framed. And I remember, the discussion came up that if they had framed it in a different way, that maybe the family's choice might have been a little bit different. And certainly everybody, I think, these days reads social science and behavioral economics literature, advertising, that sort of thing. And so we came up with the idea of discussing how our understanding of human decision-making as it continues to evolve might change how we approach informed consent. So the format will be that each of my colleagues will give a 10-minute informal talk, and then we'll have about half an hour for a lively discussion among the panel, but also very importantly among the audience as well. We look forward to your questions and comments. And at the end, for the last 10 minutes, we'd like to steer the conversation a little bit towards the idea of coming up with a potential research agenda that might be able to help clarify some of these issues in our approach in the future. And so with that, I'd like to reintroduce Doug Hough, who, as Michelle mentioned, is an associate scientist at the Bloomberg School and an economist by training, and his work has migrated towards behavioral economics and specifically its connection with health and healthcare.
Thanks, Josh. It's a pleasure to be here today. You can hear this, right?
Yep.
Yeah, it just seemed a little odd from the front. Yeah, I often start my presentations by going, "Hi, my name is Doug."
Hi, Doug.
Okay, thank you. And I am a recovering mainstream economist. Again, as Josh mentioned, I was trained in the School of Neoclassical Economics, and I'll talk about that in a bit. And I used that for years and years and years and years. And then I came to Hopkins as a faculty member in the prior school to the Carey Business School, and I was in charge of the business and medicine program. And so I would teach health economics to physicians and nurses and healthcare administrators, and I would tell the stories about health economics and all that, and the students would go, "Okay, you're the faculty member, you know this, but it just doesn't seem to make any sense. But we'll go along with it, at least for this course." And then I started reading some behavioral economics, and every so often I would throw in something about behavioral economics, and the students would go, "Oh yeah, tell us more about that. Tell us more about framing. Tell us more about loss aversion. That sounds like what my patients do." that sounds like what my colleagues do. I don't, but it's what my colleagues do. And so as I started doing this, I found both more and more things in behavioral economics seem to make sense in trying to explain what's going on in healthcare. And so I eventually converted and became a behavioral economist. One of the definitions of which is, it doesn't sound like economics, but it is. Because I'm not going to be talking about cost, I'm not going to be talking about marginal revenue, marginal cost, but if you think about what economics is, it's about the study of how to allocate scarce resources among competing ends, and in a sense it's a science, if you will, or a study of decision making. And so here's where behavioral economics can come in. So what I want to do for the next probably 8 minutes now is talk about the major assumptions of standard economics, the comparable assumptions of behavioral economics, two and only two what I call robust concepts in behavioral economics, and then apply it to a wonderful study that was published in Health Affairs in February 2013 by Scott Halpert and his colleagues from the University of Pennsylvania. So that's that. So mainstream economics makes a number of assumptions about decision making. Number one, that everyone is rational. They're always working in their best interest. Number two, that they know what their preferences are. That they know when they make a decision, that they know what they want. Number three, that they have full information. They know what the options are. They know what, if you will, the benefits and the costs are of each option, and they can weigh those in a calculating way. Number four, that their preferences are path independent. That is, it doesn't make any difference how they make the decision; they will end up at the same decision. And finally, mainstream economists will admit, okay, every so often people will make mistakes, but they will make random mistakes. So if true north is, if the right decision is that way, sometimes they'll do like this, sometimes they do like that, but it'll kind of even out. Behavioral economics says, not so fast. That's not exactly how people make decisions. That people are not always rational. It's not that they are necessarily irrational, but sometimes they are irrational. That they may not be using strictly rational methods to get to their decisions. Number two, that they learn their preferences through experience and through trial and error. Sometimes they don't have strong preferences and they don't know what they want, but they'll do something, they'll buy something, and they'll make a decision, and they'll see how that goes, and then they'll revise their decisions afterwards. Third, that asymmetric information abounds. There's almost always a case there's more information on one side than on the other side of the transaction. Fourth, that preferences are path dependent. How people make decisions significantly affects what decisions they actually make. And then finally, this is the best thing for behavioral economics in terms of trying to be a science, is that we think that deviations from rational choice can be systematic. And if they're systematic, then we can predict them. And if we can predict them, then we can be able to explain people's behavior using this. So those are the basic sort of constructs, our basic assumptions. So two robust concepts in behavioral economics, and also recognize this is a field that's only been around for about 30 years, number one. Number two, at least 70% of what is called behavioral economics we stole from behavioral psychology, just pure and simple. And in a sense, what behavioral economics is a reintroduction of psychology into economic thinking. So many of these things psychologists have known for years, and marketers have known for centuries. And number one that I want to talk about is framing. And Josh mentioned this, that how an issue is presented influences what decision is made. Marketers know this, they've known this for eons. And of course, clinicians know this. Every physician knows that if she presents the risks of a procedure before the benefits of a procedure, it's more likely that the patient is going to say, I don't want that procedure. There are different ways of just saying things that will have the influence the decision of the patient. The second thing, and again, I could go on and on and on. And oh, by the way, I have a book. Just kidding. Actually, I do, but that's not The second thing is something called the power of the default. This is made famous by Cass Sunstein and Richard Thaler in their book Nudge, and also their wonderful article in the University of Chicago Law Review called Libertarian Paternalism is not an oxymoron. It's also been advanced by one of your own, Yashir Sagai, who's done some really nice work in what he calls surviving nudge. Really some nice work there. And so the idea here is that if you give somebody a choice, but you say that one thing is the default, it's the one that's checked, then that significantly influences what decisions are made. With one little caveat here, and that is if the decision maker does not have strong preferences. A number of the experiments have shown that if individuals have strong preferences about A over B, if you make the default B, they will go back to A. But if people do not have very strong preferences between A and B, they may sort of like B, but sort of like A. If the default is A, then people will more likely choose A. Let me give you an example of that, of the work of Scott Halper and his colleagues. It was published in Health Affairs in February 2013. The article was Default Options in Advanced Directives Influence How Patients Set Goals for End-of-Life Care. One of the wonderful things about this study is that it was not done with a bunch of Cornell or University of Pennsylvania undergraduates who were doing this to get a little bit more money. This is real people. These are in fact 131 adult patients at the hospital of the University of Pennsylvania who have incurable diseases of the chest. So these people have real conditions. They are facing this decision of advanced directive. 2 minutes, that can't be. So they gave they had a choice among 3 advanced directives. One is what was called the comfort choice, which is, I want my healthcare providers and agent to treat me by helping relieve my pain and suffering, even if that means that I may not live as long. The second one, known as the life extension advanced directive, I want my healthcare providers and agents to treat me by helping me to live as long as possible, even if that means that I may suffer more pain or suffering. And the third one is, I do not want to specify one of the above goals. My healthcare providers and agent may direct the overall of my care. What they did was a randomization of those 3, in that 1/3 were given all 3 choices, but with the first one, the comfort one, checked. The second one, the second third, were given the same 3 choices, but they also had the life extension advanced directive was also placed first and was checked. And the third one was that they were given all 3 choices, but nothing was checked. So what came out of it was that 77% of those with the who had the comfort advanced directive as the default picked comfort care as the advanced directive. 61% of those who had to make an active choice, that is, there was no default, they picked the comfort directive, and only 43% of those who were given the life extension as the default checked comfort care. Now, as it turns out, so obviously, obviously there was an impact of the default, not completely, but there was a significant impact. Now, all of the participants were debriefed after the study, and were told about the default options, and told that some people got this, and were told, this is what you chose, would you like to choose something else? Of the 91 who completed the study, only 2 changed their choice. So they stayed with that particular choice. You would have expected from standard economics that you would expect about 60 to 65% of people to have picked the comfort care, the comfort advanced directive, because that was what was picked when they weren't forced to have a choice. Now, as it turns out, these participants were contacted 2 months later, and they were asked, how satisfied were you with the advanced care planning that you did during this process? And on a score from 1 to 5, the average was a 4.5. And there was no significant difference among any of the study groups. So it wasn't the ones who were essentially were given a default. They felt that they had the same satisfaction with their decision making. So, now their conclusions about this was that default made a significant difference. Not entirely, but it made a significant difference. The second thing was that preferences for end-of-life care were not strong, even among these folks with incurable diseases who are facing this issue. Again, these are not college students for whom end-of-life care is far down the road. These are people who know that they have to make this decision, or their providers or their loved ones have to make the decision. Now, the implications of all this for consent, and now I'm finishing up, is that, and this is coming from Halpern as well as some thoughts that I have, is that informed consent needs to be more of a process and a conversation, not a completion of a form. It's not just check the box and move on. It's clear that from this study at least, that even people facing these decisions do not have strong preferences, and they need that conversation. Second, this informed consent needs to be done when the patient is in a cold state, not in a hot state. Don't do the informed consent as the gurney is going toward the OR. This has to be something that's done well before that. And the third thing is that informed consent takes time, which most providers do not have. So one of the things I think that this study and other aspects of behavioral economics can bring to the bear is that we need to find mechanisms by which people can give true informed consent.
Thank you, Doug. Next we'll hear from Mark, who's an assistant professor of economics and management, who has interest in health economics and experimental economics. He's conducted large-scale randomized controlled trials in the U.S. and developing countries. And I find this very interesting. Some of his research interests are at the intersection of economics and ethics, which leads to some very interesting conclusions.
Okay. Thank you very much, Josh and everyone. It's really great to be part of this panel. I had two confessions to make. The first confession is that I discovered how I'm addicted to PowerPoint. So when we agreed to not to use PowerPoint, I agreed, yeah, sure, why not? But it's a very different way to prepare, and I hope that my withdrawal doesn't show too much. Second confession is that even though some of my research has to do with behavioral economics, I'm more of a mainstream economist, much more mainstream than that. And as mainstream economists do not enjoy good reputations, so we fail to predict the financial crisis. Some of us have caused the financial crisis. But even before then, we accused of our discipline being based on rather heroic assumptions. One of these assumptions is rationality, and that is absolutely right. Economists typically assume that all transactions, all decisions that people make are typically fully voluntary, fully rational. This means that whenever we are facing a decision, contemplating entering a transaction or making a decision, we evaluate costs and benefits. If there is uncertainty or risk involved, we may form expectations of costs and benefits, and we choose a certain course of action only if it makes sense for us to do so. So we believe in the so-called revealed preferences principle. If a person takes a certain action, then it must mean that it was in their best interest to do so. So we do assume that all transactions are fully voluntary. So now, informed consent. So informed consent is required for participation in research involving human subjects and in clinical research in particular. My understanding is that there are at least two reasons why we care about that. First is just a basic, absolute principle of respect for individuals. We want to avoid that participants are deceived or coerced. So we want, when they decide to participate, we want them to have fully understood what they're getting into. They're taking part in the study, the conditions of the study are, the risks involved, etc. The second concern I believe that we have is that we want to avoid situations where a subject or a participant would have been better off not entering the study if he or she had fully understood the conditions of the study. I'm not talking about an ex post regret, exposed. I can suffer if I participate in a study. I can suffer some side effects. That's not what I'm talking about. I'm talking about, and from an example point of view, if I had fully understood the risks, for example, or some of the other conditions in the study, I would have been better off in not participating. So we are concerned about this possibility. So we would like subjects or participants to fully understand the conditions before they decide to enroll in a study. Now, unfortunately, there is evidence that indicates that a lot of participants do not have a satisfactory understanding of what they're getting into when they decide, when they agree to participate in a study. Now, some of these studies, my understanding is that there are some issues with a lot of these studies. I'll come back to those later, but the conclusion that a substantial fraction of participants do not have a satisfactory understanding of the study's conditions when they decide to enroll seems like a solid finding. So which calls into question the fully voluntary nature of participation. There's one additional point that I would like to make about this, is that the presence of compensation makes this problem even worse. At least in the US, my understanding is that compensation is typically provided for participation in clinical studies, depending on the study. Phase one trials, for example, they pay an average of $2,000 to participants. Less risky studies pay less, but more or less about 2/3 of studies conducted, clinical studies conducted in the US, involve some form of monetary compensation. Now, there is a general perception that payment may cause undue influence or coercion in participants. And there are two studies, one recent studies, one by some bioethicists and one by economists that confirm these concerns. Firstly, there's this study that I recently discovered by Emily Largent and co-authors that it's a nationally representative study of IRB members and human subjects, professionals. And this study finds that when payment is involved, the perception by IRB members is that there's some undue influence and some coercion. The most, to an economist, the disturbing finding from this study is that the perception is that the majority agree that subjects are coerced when the payment makes them participate in the study when they would not have otherwise participated. But to me, to an economist, that's basically the definition of incentive. It's something that makes someone take a certain action that they would not have taken otherwise. So to assume that the presence of a payment necessarily is associated with coercion, that doesn't seem like the right assumption to make. So that's something that I think we should think about. Yet there is this perception that payments are associated with undue influence or coercion. The study by Alvin Roth and co-authors, a team of economists, also confirms that this is a study of the general public perception by third parties of whether a participation in clinical trials was fully voluntary when payment was involved, confirmed the same kind of conclusion. One interesting finding by this study is that the higher incentive, the stronger the concern by third parties and coercion or undue influence that take place. And also that high incentives cause regret, meaning that more people would have been better off if they were never given the opportunity to even enroll in the study. So from an ex-ante point of view, the payment made them decide to enroll in the study when they would have been better off not even having that opportunity. So this is the perception. There are several mechanisms that could give you this. So when payment is involved, particularly when the payment is large, which is the case when the study is more risky, the prospective patient might focus on the payments and disregard the rest, the information, disregard the other conditions, and just simply even choose to disregard them or downplay the risk. So there are some serious concerns there. So we have these facts. A large fraction of research participants do not seem to understand what they're getting into. Second, because of the presence of compensation, this could be actually even worse. Because the presence of compensation might be one of those factors that leads to poor comprehension in the first place. So I have two main sort of ideas some inattention might actually be rational. So we face a lot of decisions every day. I mean, some are small, some are bigger. And basically all of the decisions that we face require us to put some effort into understanding costs and benefits, what is involved, for implications, evaluating risk. Sometimes we don't have the time or the brain power to fully devote our time and attention and mental power to each of those decisions. So what we do, we follow heuristics, we essentially look for signals, and follow heuristics that more or less we believe are associated with the right choice for us. So in the case of clinical trials, say my doctor is running a study and my doctor suggests that I participate. She's my doctor, I trust her, she thinks I would benefit or contribute to the study, so those are signals that I take to sort of bypass, she has given me those 20 pages of informal consent to read, but because I trust her, because I don't have time, my brain power is limited, I say yes, and I participate. Or, it's a study run by Hopkins, it was approved by an IRB. Again, I look for those signals of quality or protection that make me feel that, look, I don't really need to read all of those pages. It's good enough for me to know that I can either benefit or that I can contribute. Society can benefit from learning whether a certain drug works or not. So my sort of first thought is that we might have fully voluntary participation, even in the absence of full or even satisfactory understanding. I might choose not to understand fully. Those signals are good enough for me to decide to. Now, this doesn't mean that poor comprehension is not a problem, for at least two reasons again. First, the study might suffer. If the subjects, if the participants don't understand what they're supposed to do, then the study might actually really suffer and be invalid. Second is that, again, for poor understanding might mean that might cause regret, might mean that I, as a participant, might have actually been better off not participating in the study. I might suffer harm from participating in the study. So what to do about this issue? My sense is that we don't really know what the actual consequence, with a few exceptions, we don't really know what the actual consequences of poor understanding are in terms of harm to the research participants or in terms to the validity or the success of the study. And Nancy has here has some very relevant recent research. Most of the studies that have looked at understanding in clinical trials didn't really look at actual clinical trials. They looked at they used simulated situations. To my knowledge, so the Macis study is one of the first who have actually looked at ways to improve understanding and comprehension in actual clinical trials. But my sense of the literature is that this kind of knowledge is very limited. In particular, there are no studies that look at whether understanding of poor understanding is associated with changes in the composition of the subject pool, which could again adversely affect the study, or actual outcomes for the study participants. For example, adverse effects of the treatment or adherence to treatment. So I see that I think that a useful next step for a research agenda to understand how the consent process can be improved first, and second, what the consequences of poor comprehension are, should go into the field and try to do more work like Nancy's work, expanding to actual consequences for patients' health and for the studies.
Thank you very much. All right. Our last speaker, who I think might change our views on what rationality is Debra, who spent her career studying medical interaction dynamics and is especially interested in the interplay between analytic and effective responses to provide communicated information and its impact on patient engagement and decision making.
Thank you. It's really fun to be here and fun to be in an illustrious economics panel. My inexperience or naivete with money would say that it's exactly right that I'm talking about the non-analytic aspects of decision-making and its involvement in consent. There are 4 ideas that I want to convey. I'm starting by giving you the overview because if I run out of time, you'll know what you're missing. And perhaps we can bring it back into our discussion. So the 4 ideas all relate to the interpersonal interactive process by which decision-making and consent occurs. The first of these ideas is to talk a little bit about the focus on instrumental aspects of communication. And by instrumental aspects, I mean the substantive content. Have we gone through the protocols of weighing risks and benefits and alternatives? Have all of the elements of responsibility on the part of the subject and the institution been outlined? So I'm going to talk about that and how that relates to what the process really is. The second idea that I'm going to throw out is that we've been doing it wrong. And the reason that we've been doing it wrong is not just our era, but relates fundamentally to Descartes' era. And I'll talk a little about Descartes' era and a second era that is made, Descartes' era number 2. The third idea is to talk about modes of experiential and analytic thinking and decision-making. So what you've heard from my colleagues is a surprise to economics, and perhaps framed by behavioral economics, is that not all decisions are rational. The aspect of non-rationality that I'm going to talk about is experiential knowing. And what I'll argue is that non-analytic, this intuitive experiential sense of knowing, is actually quite rational. It's just rational in a different way than analytic thinking is rational. And finally, I'm going to end with this notion that we could think of transforming the consent process to an empowerment process. And what might that mean? We know a lot about patient empowerment and the characteristics of empowerment, and they're not seen in the consent literature, as far as I know. So, and we'll have a great discussion, all of us, about these issues. So first, what do I mean by the limitations of the instrumental aspects of communication? Well, I think that it is undeniable that when we think of the conversation around consent, even when we think of it as the process of consent, it's overwhelmingly thought of as protocol-driven. As I had mentioned a minute ago, protocol-driven in being complete in presenting risks and benefits, alternatives, risks and benefits of all of the alternatives, and the specification of the protocols, including demand. And that is seen as the primary vehicle by which the bioethical precepts of protection of patient autonomy is protected. It's not that a patient's feelings and emotions are not important, but they're addressed explicitly through the medical dialogue, saying things like, I know this might be concerning, I'm sure, you're worried, and this causes anxiety, but it's really limited to those explicit recognitions and perhaps an appreciation for nonverbal channels. So when somebody says nonverbally, you might say, well, I can see that you're somewhat anxious about this. But it's very much a surface domain by which the emotional experience, the experiential knowing of what is being asked of you in this consent process is. So that's the first aspect of communication that I think is important to appreciate. There are, of course, or maybe not of course, but there are methods of digging deeper into the nature of that verbal and nonverbal exchange. And I can talk a little bit more about that in a few minutes. But I want to talk to the second notion of why I think it's a mistake to focus on this surface and even unpacking a bit of a deeper than that surface notion of what is happening in the consent process. And I mentioned that I thought this was an error, and it wasn't just our error. It's part of Descartes' error. And so what was Descartes' statement? It's that reasoning and moral judgment and the suffering that comes from physical pain and emotional upheaval can exist separately from the body. The resulting body-mind schism, it's been criticized, largely dismisses the body and regards the conscious self as the rational and truly human self. So I think, therefore I have to be able to understand, to appreciate the feeling by which I am experiencing the moral judgments that I'm being asked to make. I'm a big fan of Damasio, and you probably know that because his book is called Descartes' Error. And according to according to Damasio's notion of what Descartes' error is I love this quote of Damasio. It's that Descartes sees the sizable, dimensionable, mechanically operated, infinitely divisible body stuff to be separated from, and this is Damasio's notion of the experiential. He said, to be separated from the unsizable, undimensioned, unpush-pullable, I love that notion, non-dividable mind stuff. So all of those experiential notions of moral judgment and consequence are felt here. I always do that because this is my center of emotional knowing and feeling and suffering. It's not here. Although my friends often go like that. I go like that. So there is a mind-body thing that's happening. And, oh my gosh. Okay, so the error two is that this schism, it applies to the patient experience, which is similarly disembodied. And here I want to say the experience of feeling of knowing. And it comes from the literature, which is based on experiential and analytic systems of thinking. This is my third point. And so the experiential elements of thinking, and lots of this is reflected in Damasio, is that intuitive, quick, holistic gist that you get, as opposed to the analytic system, which is much more considered and tempered and rational, supposedly. I think both of them are rational because often the intuitive experiential is considered the shortcut by which we then view. So we know what we think, we know the decision that we're making before we analytically figure out why we thought that. So that's important. Finally, my last point, I have it for, and I shouldn't belabor it because I think it can be in a discussion, is that thinking about the consent process as this cognitive and rational conveyance is not just to protect autonomy, but is to promote empowerment. And the key element of that is guaranteeing or facilitating patient agency in considering their own perspectives. The empowerment definitions are involving an individual in reflecting and implementing self-identified goals and objectives. The self-identified goals have to be concurrent with what is being asked of them in a consent. So going through that notion of what does that process mean to engage people recognizing agency in self-setting these goals is an important one. It's also important that through, at least according to theorists who look at patient empowerment, that this process not only encourages and reinforces agency, but it helps build the confidence and competence and motivation to take the action. So a decision made not only because you understood, but because you felt confident, competent, and motivated to make that decision is a mark of an empowered patient. So, thank you.
Thank you very much. Thank you to all the speakers. Now we'd like to encourage the audience to ask questions. I can take a prerogative and ask the first question. I wonder if the time spent during the consent process is absolutely key. So, for example, Doug mentioned the conversation, and Debra mentioned a gist, and I think from the creativity literature that often these gists or these aha moments come after a certain period of time spent in more analytical reflection. Do either or both of you feel like consent that happens over time when it's possible is going to be more reflective of the patient's preferences than one that happens, for example, in a single session?
Well, I don't know, but I would say I don't think that intuitive sense of knowing follows analytic thought and thinking. I think it comes as a cognitive shortcut and an emotional integration. So how that relates to analytics, what Demacia would say is that it often comes first. You got to take either I like the way you look, I feel I can trust you, I have this frame that allows me to go on, or coloring everything that you say through that frame, or I'm thinking about my deceased sister who was here. So it's integrated, in that sense. Maybe later we could talk, what I thought you meant about time was how much time does this take? And, as Mario said, or maybe Doug, doctors don't have a lot of time. So maybe we can talk about that later too if people are interested.
Yeah, I just think it's something to follow up. The more I've thought about the Hopkins study, the more, if you will, not confused, but I think there are some deeper conclusions to reach on this. Remember the thing I said that 2 months later, people were asked, were you satisfied with your decision? And they said yes. In some sense, if they're satisfied, why should we be any concerned? Because they made a decision, they're comfortable with it, even if they were influenced by the default. If after over time they say, well, that's the right decision for me, then who are we to have to worry about that? I mean, that's for them to worry about. Then my counter to that, after all, I'm still an economist, so I do on the one hand, on the other hand. And the other hand on that is, yeah, I would think time would be a good metric by which people, giving them enough time to not only consider but reconsider. If in this study, essentially no one reconsidered, then is time really going to be a critical factor on this?
Please.
So I wanted to go back to something that Mario said that I think then relates to something Debra said, that I have a hypothesis that a lot of that sort of gist or intuition happens perhaps long before they enter the door of Johns Hopkins. That the sort of how they frame institutions or frame their futures, they either involve a high-tech medical institution or they don't. And I'm wondering if that changes anything about, do we need to then know more about the type of person who comes and then figuring out what type of information might be best in helping them make a decision?
I want to make one small comment to the previous question, and then to me, these are all different questions. A lot of these questions could actually be settled with an actual randomized control trial where different prospective participants are offered different types of informed consent, and then they follow over time, and measurements are taken about just whether they're satisfied with their decision or not, because that sometimes 2 months later or 3 or 6, people might engage in ex post rationalizations and so. But looking at actual clinical outcomes, see whether people who were poor comprehension or who were offered standard traditional informed consent forms actually displayed disproportionately higher adverse reactions to the treatment. So actual concrete health outcomes like that.
Can I comment on that just a little bit? Because I think there are two things. One is, can you guys hear me?
Yeah.
One is that this notion of GIST, in terms of general orientation, certainly may have been established when you were 4 years old and hated coming to the doctor. But I think that there's something else when we think about this notion of experiential learning that is happening in incorporating new information and the feeling of new information as it's being conveyed. So it's a little bit different. I think that the process of consent, for me, is a reflection of the up and back, the interaction that's occurring between that patient and whoever is helping them facilitating the consent process, whether it's their own physician or the nurse or and social worker and outreach, whoever is doing that engagement process. And when I talked about the empowerment notion, the empowering, making consent an empowering process, one of the really critical things, at least I think, and you see it in a fair amount of the empowerment literature, is that empowerment is facilitated through a collaborative, engaged, patient-centered relationship. And what does that mean? That engaging relationships helps people think about it, not just analytically, but emotionally, work with how they're feeling about the content of what is being said. And so for me, and not perhaps my economic colleagues, is that I see that process as housed in an interpersonal relationship that can be empowering and facilitating, or it can be kind of dehumanizing.
So no, I actually agree with this, and actually what you're basically providing is what we call the micro foundations of our theory. So you're basically saying what should happen, concretely. So when a patient walks through the Johns Hopkins doors, he knows that this is Johns Hopkins, it's a reputable institution, that we don't just experiment on patients. There are processes in place. That's a very important component of the quality of the signal. And so the fact that what I said earlier, that some of our inattention is rational, doesn't mean that we as researchers or clinical researchers, you are exonerated from, responsibilities. Actually, rational inattention makes people more vulnerable to, being coerced, being deceived. And so there's a lot more responsibility on the part of who is conducting the study to make sure that the trust that has been built to ways into personal relationships is well placed. So it's a very important concrete steps so that those signals that we send and that people rely on can actually be relied on. So I don't think we're saying very different things.
No.
I was going to just ask to build on this notion of empowerment that you brought up and put it into dialogue with the frame that was invoked in the first talk, which was the neoclassical economic frame, around the issue of endogenous or exogenous preferences. And in thinking about whether or not the kinds of interactions that go into eliciting consent are not only sort of informational, but also for people part of how they are empowered, how we form. Preferences are there criteria that we can, if those things are going on always simultaneously, and that's a hypothesis, but would we be able to articulate, I guess, norms or to delineate bad preference formation experiences from good ones that are empowering, I guess that's a good term, from ones that are sort of pernicious indoctrination or something like that, where it's the wrong way of forming preferences?
So a short answer is that if we look at this notion of empowering learning relationships or empowering provider relationships, that the characteristic of those is that they allow for self-identified and self-set objectives and goals, whether it's in learning or something else. And for consent, it is a shift in some regard, the whole frame. It's not the objective is to get you to consent to what I want to do. It is to engage you in a two-way dialogue so that I can help you come to a decision which reflects where you're at in terms of its relationship to how you might self-identify your own goals and objectives in regard to participation in a project. So actually I teach a course third quarter, so I'm not going to spin a book, but my third quarter course is on health literacy, and today's lecture actually is on educational empowerment and Paulo Freire's notion of the empowering learner-educator relationship and how that is reflected in facilitating literacy and health literacy and things like that. So I've been thinking a lot about that notion, and perhaps later we can talk some more about it.
This was in response to Doug's, I guess, that question about the Hopkins study. I mean, it's interesting when you ask, is that, if people are satisfied in the end with their decision, then is there anything wrong with that, or is that, and I wonder, we know that people will try to do or say things to reduce cognitive dissonance, right? So is it somehow, and that can be used in different, I'm not saying it's always bad to sort of take advantage of that principle, in certain situations, but is it okay in this case? Is it sort of exploitative to use that, I guess?
My probably semi-short answer on that is going to pick up on something that my colleague Mario had mentioned, and that is what economists look at is revealed preference. Not what people say, but what people do. And if people are given and here's where I guess I'm coming back to my roots of mainstream economics. That is,
There's no escaping this.
there's no escaping, yeah, it's still there. Is that if people in given multiple chances to change their decision or change their action, choose not to do so, and you're able to do it in non-coercive ways so that they don't have to face whatever regret or cognitive dissonance, and they don't change, then are we led to believe that, or then to conclude that they made the right decision for them? Did they make then the rational decision?
But how can you eliminate the possibility that that conflict, that even if there are no consequences, perceive that if you're not presenting any consequences for them to change, their own conflict of, well, I made this decision, so I don't want, so I'm going to stick with it.
I'm not going to change it back, because now I'm going to have to think in a totally different way. That I said I wanted comfort care, but really I want life extension care. I'm going to plead almost complete ignorance. Economists can have value in some settings. This is where I don't think we have a whole lot.
And I think, as we talk about the idea of a research program, this gets to the issue of what we put put up as our gold standard against which we measure whether we're doing well or not so well. And some of the thoughts that have come up today is, whether they're satisfied with their decision X period of time out. But as you mentioned, there's a consistency bias where people might not change it just because we like to be consistent with what we said previously. And CLD's book on persuasion, and so on. Or there's the idea of whether we were satisfied with the process and felt positive about it, but certainly there's a possibility of bias from the personality of the person involved, who's providing the consent, or is the clinician involved, or as Marius suggested, the possibility of actual health outcomes by some objective measurable standard has less to do with patient preferences, but that's the other possibility. And of course, some of this could all be biased. I said we have a study, that will survive 1 out of 100 times, and it's worse than the standard of care if you happen to be one of the lucky people. Even though nobody would probably consent to that, if you happen to be one of the lucky people, the outcome is good, or another, in the opposite case where the outcome is bad. What actually ends up happening could influence, or almost certainly will influence, I would think, the perception of whether the patient felt like they had made a good decision or a bad decision by participating. Anyway, I saw a question in the back.
Just a comment on Mario talked about the potential issue of compensation being coercive in the context of clinical studies. I think you have to be very careful. You can't lump all studies or research projects together. There are many, many projects in which, for one reason or another, the patient or the subject may perceive that there's a potential benefit to entering into the trial. Many chemotherapy trials, oncology trials fall into that. And I think if you look at those trials, compensation would have no impact at all. People are entering those trials because of the somewhat misperception of therapeutic benefit from the trial. Now, in other studies where there is no potential treatment being offered, you might be right. Their compensation might have an impact if it's really excessive, and I really don't think it's excessive in many studies. But you can't lump all the trials together when you look at compensation.
Thank you so much for your comment. I was wanted to clarify. I wasn't counting. I was relating the results of a study, of 2 studies that indicated that there is widespread perception that compensation is associated with coercion, or at least undue influence. So those are findings among IRB members and also among the general public. I don't necessarily share those views. There is a widespread perception that payments, especially when they're large, they might adversely influence comprehension and induce patients to participate when they would have been better off not participating. But I have done research on the role of compensation in inducing people to take certain actions in health-related settings, and I'm very much sympathetic to what you said, and also about the importance of not lumping all studies together. Absolutely. Thanks.
If there were any other questions, but I don't see one. First, I just want to say on behalf of all, this is a fantastic panel. Partly you've given us so much to think about, and we're going to have time for this research agenda, whether or not. Because if we don't, I won't ask my question. Where are we on?
I think we have 3 minutes left, and I think maybe if we just say, I don't know if there's much more to be said about a research agenda, or if we just...
Actually, I do.
Oh, okay.
But I'm going to defer to...
Okay.
Well, maybe, I'm not going to ask afterwards, but just my quick response is that the different takes that each of the 3 of you have are in some ways in conflict, and in some ways they can point us to the question you left us with, which is what is the gold standard. So the problem I have with the study that you like so much, Doug, is it begs the question of when it is ethically appropriate to set defaults, right? Debra raises the challenge, if the goal in some cases is truly the empowered patient in the context of consent, then where that's the right goal, setting a default seems completely inappropriate. On the other hand, when Mario talks about selective intention and 1,000 decisions, there may be all kinds of contexts, very low-stake research situations, very benign, low-stake situations, where we don't have to worry about what happens to selective intention, and setting a default is probably ethically permissible. So some of this sort of, to me, this wonderful sort of picture that's coming together, this great research agenda, is how do you figure all of that out, right? How do you figure out how you take the best insights and the obviously intense knowledge of each of these three different perspectives in a way that gets us to a sort of ethically better, more nuanced set of strategies for different clinical and research contexts.
Do you think there's any role for things which are done on the large, or communication which happens on a large scale versus that which happens within a particular one-on-one patient-clinician encounter? Yeah. So, for example, just to phrase it this way, if there were exceptions that there's some governmental form that has to do with end-of-life care, and we're discussing the news that we know that if we put this default, it will whatever, but any individual patient is happy to change it. Here's our rationale for putting this default in the way, given the more important thing to choose this way based on the default that we put in. Do you think that that can be ethically justified?
Do you want to ask an economist about ethics? No, I meant that really.
Well, I think that's a really interesting question about scale. And, my thinking is that there is a relationship, an empowering relationship that occurs on a one-to-one basis, and that it's part of the delivery style of consent. So it's not just protocol adherence, which is the kind of things that Nancy and I've done many times. Did they name all of the risks and benefits and things like that? The delivery style is one that recognizes and the agency of a patient, puts the patient in the middle, and that this becomes, something that is not, I'm there to get your consent, but that we're going to work together. So the question of scale, so, and that I thought is an interesting one, because there are interactive media approaches, and things like educational photonovellas and games and all of those kinds of things that can engage a learner in setting up, and facilitate that whole process. So I don't think it's impossible, but it's different than providing somebody with a form that has a default check versus not. Unless, so my bioethics friends, unless the goal there is not protection of individual autonomy, but, social justice, for instance, or, a different kind of beneficence that is taking care of the public good as opposed to individual goods, like, perhaps the default on organ donation at the DMV, where that's a default. So I think it's an interesting conversation.
So we are out of time. So